is a second generation and fully battery operated automatic CPR device, compact, lightweight, portable. EMS services, St. John's ambulance, and also hospitals are mostly using this device. Other devices like action decompression devices and LDB are also available. Next slide. So, what are the outcome of each of these things? So, increase cortical cerebral blood flow. Basically, with Lucas, a new device for the mechanical chest compressions compared to the standard chest compressions. If the cortical blood flow is restored to a level corresponding to 65% of the baseline values, as in the present study with the Lucas device, there is an obvious risk that the cortical function may return early and patient may become conscious and become aware of the CPR. So, using electroencephalography can be seen that cerebral functions are affected with a 50% reduction in the cerebral blood flow. Next slide. Now, what has happened is when you use these devices, the importance is also about the strength of the operator rescuer. When this rescue operation is done by women with a smaller stature, the compressions are not uniform. Whereas it is done by men, it will have a better this thing. Even they also become easily fatigued. So at least we require 3-4 rescuers to change their hands. Now, what are the mechanical chest compression for out of hospital cardiac arrest, systematic review and meta-analysis? 2015 systematic review RCTs, over 10,000 people and out of hospital arrest, atraumatic, comparing manual to mechanical CPR. Now, what all the things that are studied? Actually the two devices, Autopulse and Lucas. Autopulse used in Aspire and Circ. Next slide. Lucas, this Merkel et al. Lynch and paramedic. You are not gone to the next slide, I think, no? But I think I'll show my hand like this, which in the time. Change. I think you have to move backward, I think. Fast. You have to move backward. Still go backward. Oh, this is over. I think go to the next one. Go backward.
You've done, ma'am. You've done.
This is done.
Good, done. Go forward.
Now you have to go for the video. No, I had a video.
Video done, sir. You're done.
Video is shown.
Done.
I didn't see it. No. Right. Okay.
Next.
Okay. So now when you look at link 2014. That slide. Link 2014. Lucas. It was used in UK, Sweden, Netherlands, multi-center RCT, 2,589 patients, survival 4 hours, manual 23.7%. And Luke, you are just going.
Next.
Are you going too fast? No. Yes, you are going too fast. No. You are going too fast.
But your time is
up,
ma'am.
That means it's better I change the slides, no?
Your time is up, ma'am.
No, time is up is not the question. You must have given me a laptop, no? Otherwise, give me another chance. Let it be a rehearsal. Okay. So, from here you will move. So, this is the first slide I showed you. How the manual compression makes a difference. How combined devices will be better for you.
Dr. Habibur and Dr. Tamiz Ahmed can please join us on the stage. So we're going to Bangladesh live very soon.
Coordinate with me. You go to that slide. From that slide, move forward. We have only several slides after that. No, go forward. Okay. Now did you show the video? Because I thought you must have a live this thing because many times they're talking about hypothetical things.
We have seen that, ma'am.
Have seen that?
Yeah.
Okay, probably as I was talking with you. No, proceed. Let's go to the next slide.
This is shown. Go next.
Next slide.
Next.
Don't go to last slide.
This is important.
Okay. So the Autopulse and then meta-analysis, as I told you about mechanical CPR, showed no advantage for ROAC, that is return of spontaneous consciousness, survival to discharge, and survival with CPC 1 to 2. Yes. And then you go for MECA. Next is MECA. Next. Next. You go for Mecca. You are not gone for Mecca, no? You see, you are writing so much.
Ma'am, please conclude.
So Mecca study, again Lucas device, Singapore, go to the slide. Singapore Mecca Center RCT, 100,191 patients, survival to discharge as treated analysis shows manual 2.9%, early Lucas 5.8%, late Lucas 2%. So ultimately mechanical CPR, what you should see is the strength of the operator, and then actually you should also look at the availability of the proper rescuers. So ultimately, I'll come to AHC guidelines. That's all. AHC treatment recommendations, manual chest compressions remain the standard of care for the treatment of cardiac arrest, but mechanical piston and load distributing devices may be a reasonable for use by properly trained personnel. The use of mechanical piston or load distributing band devices may be considered in specific situations where the delivery of high quality manual compressions may be challenging or even dangerous for the provider. Example, in situation like limited rescuers available.
Exhausting हो जाते हैं.
Who knows, even rescuer may go for a cardiac arrest or a myocardial infarction. We don't know the strength of the health of the rescuer. So in those situations where we require, limited rescuers are available. Prolonged CPR during hypothermic cardiac arrest in a moving ambulance in the angiography setting.
Sure,
during
এখন
the
আসতেছে. Sure.
preparation for extracorporeal CPR, provided that the rescuers strictly limit interruptions on CPR during deployment and removal of the devices. The indication is class 2B, level of evidence C. The last one is this one. The last one is percutaneous veno-arterial extracorporeal membrane oxygenation during cardiac arrest. So there is again, this actually I will show only this thing. Now you see, in these patients, when they used it for in-hospital cardiac arrest, they found the survival rate was around 54%. I want to cut short the thing. Survival rate is around 54%, and so small non-blinded sample of 26 patients, both incorporeal outside hospital, refractory VT/RVF, mechanical CPR, last slide, mechanical CPR and therapeutic hypothermia and ECMO, and then followed by intervention. So 54% survival is there. So the last thing is there is insufficient evidence to recommend the routine use of eCPR for patient cardiac arrest. And then the last summary is mixed support evidence. Most of the evidence is out of hospital arrest, not enough to warrant introduction of these.
Hello, good afternoon.
What's outcome?
Can you hear us?
Yes, we can hear you. We can hear you.
Thank you. Now we're live from Bangladesh. Geeta ma'am, sorry to interrupt because they are dealing with the left vein. And we have in the panel Dr. Panja, Dr. Devdatta, Shunip, Habibur and Tamiz, Dr. Panja and others, Dr. Datta will join us. Please go ahead and tell us the case.
So thank you for giving us this opportunity. And we are from the National Heart Foundation Hospital and Research Institute in Dhaka. And today we have a pretty interesting case. And before we start the case, I would like to introduce my cath lab team who is doing this case with me. And so I'm Fazila Malik, and I work at the National Heart Foundation. To assist me is Dr. Abdul Qayyum. And then our chief technician is Morshid, a very, very capable technician. We've got a senior sister, Tanzila, and we've got a gem of an anesthetist, Dr. Mohsin, and he does a brilliant job always. And apart from that, we've got other staff like Maksura and Newton to help us out. So could you see us? Yes, you could. Yeah. So now that you've seen us, and let us go to the case that we will be showing. Now, this is a gentleman who was unfortunately rejected from surgery. Why? Because he has chronic kidney disease and he had a history of CVD 2 years back. And he has fairly complex coronary artery disease. So can we, so as you can see, he was rejected from surgery because of his CKD and the CVD. And now let's go and have a look at his angiogram. Now he had very severe triple vessel disease. The RCA was anomalous in origin and had a short segment of CTO in the mid part, and it was getting collaterals from the left side, and the left side was pretty bad as well. There was ostial left main disease, and the proximal up to mid part of the LED had significant disease, and the diagonal had a disease in its mid segment. Ramos was not that great a vessel, but that was diseased as well, and it was a smallish vessel. So this is what we have: a gentleman with triple vessel disease. He has the, and another thing, very important point, was that these vessels were severely calcified. As you can appreciate from just looking at the picture, you can see the left main, the LED, the LCX, as well as the RCA severely calcified. So severe triple vessel disease with left main disease. Now, one thing that we felt is that we needed to tackle the right side first, because obviously we want to create as much support for the left main procedure. So we just now we started on the RCA and we finished the RCA, but let me go through what we did in the RCA. So as you can appreciate, the RCA is anomalous in origin and there's significant disease in its ostia. And in the ostia, you can see there's significant disease. And then there's also the short segment CTO. And then you can see so we took a right coronary catheter, and after we took the right coronary catheter, we took a floppy run through wire. And with the floppy run through wire, we were able to, can you see the picture, please? Can you show them the, yes, you need to show the picture. Yes, that's what we need to show. So you can see that we attempted to wire the RCA. So let's go how we went about, and you can appreciate that it's severely calcified. We took a fine cross microcatheter to assist us in this, and we were able to cross the short segment CTO. Once we did that, we then went on to change our wire for the wire for a this rotor wire, and then we took a 1.5 rotor bar. And you might ask, why did we take a rotor bar? Because our IVUS wouldn't go. So we first took an IVUS to have a look at the extent of calcium in the vessel. And what we saw was that the calcium was very extensive. You can look at the IVUS. Can you show the IVUS? Please show the IVUS. So in the IVUS burr got stuck in the middle of the right coronary. It wouldn't pass any further. And you can appreciate that there was almost 270 degrees of superficial calcium in the right coronary artery. So we felt that a rotor was warranted here. And obviously a rotor is such a wonderful tool to help you in this kind of situation. So what we did is we changed our run through wire for a rotor wire, and we took a 1.5 rotor burr. So once we took the 1.5 rotor burr, we did a couple of runs with it. And usually we do not use a temporary pacemaker when we are doing a rotor. We just have someone stand by with with a syringe of atropine. But here, since this was a live case, we thought that we should put in a temporary pacemaker as well. And then, as you can see, we had quite a struggle with the rotor burr. So we did a few runs. And after the runs, let us have a look at how the vessel looked. Can we have a look at the vessel now? Yes, please. Yes, so yeah, as you can see, the rotor burr gets stalled there, and it's like gentle pecking motions, and then we are able to cross that heavy degree of calcium over there. Okay, after rota, we gave a bit of GTN, and this is how the vessel looked, a lot clearer now. we then proceeded with our NC balloon. And before this, you will remember that even our IVUS catheter couldn't pass. Now we took a 2.75 NC balloon, NC Euphora. So this was from Medtronic, the Euphora, which is really a great NC balloon. And then we went up to pretty high pressures and dilated that part. We did pre-dilatation, and after that we took a 3 by 38. This was a Resolute. So because of budget constraints here, we used a Resolute. So we took a Resolute and we deployed that stent. So after we had deployed our stent, the next plan, we did post dilatation, and after post dilatation, as you can see, we're doing post dilatation because the angle, we thought that the stent hadn't opened up that well there. So we took a 3.5 by 8, again another Euphora, and went up to high pressures. And after this, we took the same balloon and did pre-dilatation of the ostia, which was pretty severely diseased. We did pre-dilatation of the ostia. We decided that we're going to put a stent. We will not put stents back to back. Rather, we prefer to put a stent, a 3.5 by 24 from the ostia downwards. A 4 by 24, a 4 by 24, a 4 by 24. Now, as we took our 4 by 24 stent, there was a bit of a challenge because we were having problem in identifying the ostia. So we took a cuspal wire to help us assist in that. And then we did a couple of shots, identified our ostia, and deployed our 4 by 24 stent in the RCA, in the ostium of the RCA. And then we did post dilatation again, and we had a final shot of the IVUS. I had a look with the IVUS to see how the vessel looked. So now our IVUS went very easily, and as you can appreciate, again, can we go to the IVUS, please? Yes, and you can see in the IVUS that the stent is well deployed, and then when you go to the ostium is well covered. Let's go. So there's a bit of a gap where there is some disease, but we didn't put any stent there. And finally, the stent goes all the way from the ostia downwards, and the ostium was very well covered. And this is the final result. So can we have a look at the RC in the, and yes, so this is our final result. So now we have secured our right side. We have put 2 stents here. We had to do rotablation. Now we have started the left side. So in the left side also, obviously quite a few challenges there. The ostia is significantly diseased. The LAD is significantly diseased. Diagonal has significant disease, and to top it, there's a huge amount of calcium all through the extent of the left main as well as into the LAD. So this is the target, the left main, that we are about to tackle. So we've tackled the right side, we've gained some support for this procedure, and now we are about to do the left side. Any comments, please?
Good morning, Dr. Fazila Malik. I'm Dr. Bhattacharya.
Hello.
The right side you did really wonderfully.
Thank you.
What we want to know is what is the LV ejection fraction and what is the EG?
The ejection fraction is 58. So good ejection
58.
fraction.
So,
I mean, in rota and in left main, if you have a good ejection fraction, that makes your life such a lot easier. So yes, the ejection fraction is acceptable. Yes.
And what is the EGFR, please?
Oh, his creatinine is 1.7 and his EGFR was quite impaired. I don't really remember from the top of my head, but it was significantly impaired to warrant the surgeons not wanting to do a procedure on him.
Okay. The reason why I ask is that you must have a strategy regarding how much contrast you're going to use.
Absolutely. Absolutely. We've been very, very sparing with our use of contrast, you know. So like when we've done the runs, we didn't take any shots, and then we just used like minimum possible amount of dye, and we generously dilated it with the normal saline flush so that we could, the amount of dye would be very, very less. So yes, we've been very cautious, and this is an absolutely learning point that all our juniors need to remember, that when you're dealing with a patient like this, you need to take notice of the amount of contrast that you're using. Yes, very, very relevant.
Dr. Maya here. Actually, it's a multiple lesion, multiple vessels. Why are you taking for the for intervention rather than the CUG?
Yeah, because
Refused. That is-
yes, because he was refused. He had a CVD and he also has CKD. So I think the CVD was more of a concern for our surgeons than the CVD. Yeah, right. Because anesthetics and surgeons don't really like a patient who's already suffered from a stroke, and that's one of the main reasons.
Okay.
Fazila, this is Shirish Reman.
Hi, Shirish. Nice
Hi.
hearing you. I heard your lecture, you know, the one that you were giving, brilliant as usual. So while we were doing a procedure, doing a bit of it, we got to see a lot of your interesting cases and all. So great job, Shirish.
But you know, this is nowhere close to what you are. I don't know what's going to come.
No,
But if I
no.
do this, surgeon would cry. That much I can tell you.
Thank you. Well, I don't know whether that's a compliment or not, but anyway, we were forced to do it, and I suppose we are not. I mean, to do it live as well. So, I mean, we've advanced a bit in this side as well. But any thoughts on what you would do, Shirish?
You any thoughts of staging? Not today, but in general, if you're on your own.
Absolutely, Shirish. That's what I was telling my chief technician, that this obviously warrants staging. We love to do staging because staging makes life such a lot easier, both for you and for the patient. And with a patient like this who's got CKD, definitely staging would be great. But here, but this was a live.
RC has taken a lot of effort, so that's another way.
Yeah.
And the other way, you can use more of IVUS to judge the stent length, etc., and keep the contrast down.
Yeah, that's what we did.
Now
We used the IVUS, and that gave us an idea about, so IVUS is, as you rightly point out, IVUS is a great tool that can help you cut down on your use of contrast. And yes, we did use IVUS. We didn't show you, I mean, the procedure totally the right side, because that's just the side of the story. But yes, we didn't use that much dye. We just went and used a lot of IVUS and did pre and post procedures and sort of assessed what we needed to do.
Thank you. This is Dr. Banerjee, Shunip. Madam, I think that we have to do the left. There is no doubt about it.
Absolutely.
Now, it is an important judgment that how we evaluate the LCX ostium. Can you show us the other views?
Yes,
I think I will be very clear that we should try to have a single stent strategy in the left main area in these complex cases. Is it possible?
Yes, I think so. I totally agree with you. Those were my thoughts exactly as well. So that's what we thought, because, angiographically, the LCX doesn't look bad at all. And in IVUS also, we found that the LCX was free of any significant disease. So we are pretty hopeful that we will get away with a single stent strategy on the left side. However, before we started the procedure, again, we did an IVUS, and this time our IVUS showed that, this time the superficial calcium amount was 360 degrees. And that's just to highlight, in patients who have CKD, you often see such a high load of superficial calcium, and a rota can do wonders in such a case. So can we have a look at the IVUS run, please, of the left main? Yes, just show the IVUS. Yeah,
This is LCX ostium.
Moshe, can you show them the LCX ostium? Yes. So this is IVUS, which shows that this is proximal part of LAD, and it's got 360 degrees of calcium. And then you go proximally. And there you see the LCX free of any significant disease. However, the left main is very significantly diseased. And as you go upstairs, so you have, yes, so the LCX is free of disease, right? The LCX ostia is free of disease, but there's a lot of calcium in the LAD as well as in the left main. But more so in the LAD than in the left main.
Fazilappa, this is Tamzid. Actually, you have a last side diagonal. Do you have any
Yeah,
plan for that? Or
yeah,
just
yeah.
leave it alone?
We do have a plan for that. So you can have a look at what we have done so far. So we wired the left main to LED, and we wired the diagonal as well. Now, if you can appreciate, if you look at the, so we've done the IVUS, and then we take our wire into the diagonal as well. And if you can have a look at the diagonal, you'll see that the ostia. Yes. So before we go to the diagonal, let me just go sequentially through the story, because now you've seen that there's such a huge amount of calcium in the proximal part of the LED. So first of all, obviously we changed a run through floppy wire with a fine cross for a rota wire, and we took the same 1.5 burr that we had used for our RCA for the proximal LED. And it was quite a struggle to do rotablation in the proximal LED. There was quite a bit of deacceleration as well. And so we did a couple of runs. And as you can see, the rota burr isn't going that happily. And we did rotablation of the LED. Once we had finished with the LED, we let's have a look at how so this is how the vessel looks, a lot clearer, but you can appreciate here that the diagonal, the ostium of the diagonal looks relatively free of disease. But however, there was a tight stenosis in the middle part, so we wired the diagonal again with a run through floppy wire. After this, we took a 2 by 12 balloon and did very gentle dilatation of the diagonal, sparing the ostium. And then we took then we took a 3 by 18 3 by 12 balloon, NC balloon. This was again an NC euphora, and this we pre-dilated the LAD as well as the left main. So this is how the vessel looks after pre-dilatation, and you can see the diagonal doesn't look that bad. Okay. So after pre-dilatation, this is what we did. We took a onyx now. It's a 3 by 38 onyx, and we took it distal to the diagonal up to the proximal part of the LED, and we deployed it. And we've still kept the diagonal wire jailed. This is how the vessel looks after deploying our stent. We did post dilatation with a 3 by 8, again NC euphora. And by the way, we just wanted to mention that for our inflation device, we use the Umbra medical product, which seems to be very effective. And this is our routine workhorse inflation device. I mean, everything matters. So just wanted to mention that.
Can we discuss here for a while?
Yeah.
Can we discuss here for a while?
Yes, sure. Go ahead.
Yeah, this strategy, we may have some different. Dr. Bhattacharya, what do you think that we should predilate LED diagonal area?
Yeah, no, we were discussing. Why did you feel it important to dilate the diagonal? Because you could dissect it. You cannot predict what the balloon is going to do to the diagonal, and you have not done anything to the ostium.
Yeah.
So that is our question.
Yes.
Why not just leave it alone and proceed with the LED?
Absolutely.
Keep a wire in the diagonal.
Okay, so absolutely, I totally agree with you that would be a very good strategy to avoid doing anything to the diagonal. However, when we, after the rota, when we took a shot of the diagonal, you might recall that the diagonal ostium was free of any significant disease. And there was a significant amount of lesion just distal to the ostia. So that made us think that, okay, let's be very gentle with a balloon and dilate it. Now, as you say, I totally
Ajala,
agree.
you can give
If we had
this stent,
dissected it,
Ajala,
we would be in big trouble.
you can give this stent, but Dion is very intermediate size. You can give that T stent, micro T stent
We didn't want to
in
make
the
the
tube.
procedure any more complicated. So as you have rightly pointed out, we could have left the diagonal alone, which would have been a great strategy. However, we were lucky, and when we did dilatation with a gently with a balloon, that worked well for us as well, actually. So and after post dilatation, we rewired the diagonal again. And the wire went easily. So we've got the diagonal under control, and let's see what we want to do with it. But as you have already pointed out, we are happy with what's happened to the diagonal. So this is up till now what we have done. We have seen by IVUS that the LCX is free of disease, and we hope that we will get away with a single stent strategy. The ostium of the left main is significantly diseased, and obviously when you do ostial stenting, there is a challenge that you want to cover the ostium and not miss it. And here, to top all these complications, this patient had very significant calcium, which warranted rotablation. So we have done up till now. This is what we have achieved, and now we will be proceeding with the stenting of the left main to LAD, and our plan was to use a 4 by 3.
Fazila, I
Yes.
would feel now that you have wired the diagonal and put a stent in the distal LAD, mid and distal LAD, your first stent, you might as well finish diagonal with T with protrusion, so the diagonal chapter is over.
But
And then you have time to put a stent on the backside. Because once you put an ostial left main stent, taking another stent, this wire is going to be a trapped wire and so on. So maybe you complete the job on diagonal, whichever you want. Either leave it, or if you're going to stent it, since you put a wire, I'm telling you.
you know we've decided to leave it up till now. With the results that we've seen, we are very happy with how the diagonal
Why
is
not
received,
remove the,
and we don't want
why
to
not remove the wire? Because the wire is going to get trapped
no,
unnecessarily.
we'll get the
Yeah.
wire. But when we deploy our absolutely, when you do a left main stenting, you don't want a wire hanging around in the diagonal. Absolutely. So we will take away out the diagonal wire when we put a stent in the left main. That's for sure. Never
The
ever
other issue
change.
is, where is your left main stent going? You're going to cover the ostium, right?
Yes,
Absolutely.
absolutely, absolutely.
Left main, look, this is all the way to the ostium.
Yeah, you want to have a look at the ostium. That's pretty severely diseased as well. So we can have a look at the ostium also. We've done pictures. Yeah, we've already checked the
Your
ostium.
IVUS too would have shown you something.
Yes, the IVUS also. Can we have again a run of the IVUS? IVUS, please. So IVUS again. Let's go to the IVUS. So there was a significant amount of disease in the ostium of the left main. So this was the LAD, very significantly diseased. And then as you come proximally, you can see that there's significant disease in the.
5 more minutes for the transmission.
Okay, so we'll
Please
take
come.
our stents. Yes, so let us take our stent from left main to LAD, and we'll be removing the diagonal wire stent. However, we've put a wire in the LCX just to be in the safe side. Even though we know that the LCX is free of disease, we just kept a wire in the LCX to be in the safe side. So now we are taking a stent from the left main to the LAD. So can we have the picture, please? Yes. Let's not see the RCA. We need to see the, yes. So this was, and this is a 3.5 by.
LMCA, which stent it is?
30.
Ajala, which stent you push in the from LMCA to?
This is a Resolute Onyx. It's a Resolute Onyx, and we're using
yes,
it
which stent?
because you can post dilate it to like even 4 if you want to, and we plan to do a report later on. We want to do a pot, obviously. So this is a Resolute Onyx going in now. There's quite a bit of calcium there, right? So you think the stent is a bit? Yeah, we will pull back the diagonal wire, please. Yeah, this is the diagonal wire. So we've removed the diagonal wire and it comes out easily.
diagonal wire এর জন্য অসুবিধা হবে না।
We can get,
He may record further dilatation in that area.
yeah, I might.
Okay.
Can you take the circumflex wire out
Not right
and
now.
try?
We might need
No,
to pre-dilate
try to get the stent pin by first pulling the circ wire out. The circ wire is not serving any purpose at the moment.
Yeah.
we,
that is
I
also-
think we can pre-dilate again.
Yeah.
Yeah, that is a recourse.
We will try to engage our catheter as much as we can, and let's see again. So it's in.
এই চলে গেছে।
It's in.
That's very good.
Yeah.
Yeah,
So-
nearly reach.
So we'll pull back our.
Oh, nearly reach it.
So
না না নিচে ঢুকে পার করে নিল না নিচে ঢুকে না পার করে নিয়েছে। হুম।
Okay.
What view is this? Elocranial. Okay. No, it's not elocranial, it's epicranial. Yeah, go to elocranial, that's right.
this is
No,
this is
cranial.
iliocranial.
Can you go,
This is iliocranial.
can you go a bit more steeper, so that we can see the ostium? So
Yeah, there is some overlap.
can you give a puff there?
Are you happy with the position?
This is probably okay.
Yeah. So
What-
we'll
What
deploy.
you don't want is a lot of lint hanging out because you run the risk of proximal compression with that guide catheter. And I'm sure you would want to repeat IVAS after this.
Yes, absolutely. If we have time.
I think now it's okay. Very difficult to predict because in spite of calcium that thing.
This is a 3.5,
Yeah, this is a
This is a
3.5.
four?
It's a 3.5.
3.5.
3.5,
Okay. So what atmospheres are you at?
We went up till 16.
Okay.
Okay, 3.5 in the LMC, it could reach into 4.75. It is ideal strength on
Negative,
the
negative,
LMC.
negative, negative.
Pensile.
বাইরে আছে হ্যাঁ না না বেলুনটা টেনেছে মনে হয়। হুম,
ঠিক আছে।
বাইরে আছে না না ওটা বেলুন
Negative.
করছে।
Another 1 millimeter it will be happy.
You have pulled the balloon out into the ostium, no?
Yes, yes.
You're flaring. Okay. Yeah.
Now we're pulling out the balloon.
Yeah.
Now we'll do post dilatation with a 4.
Can you do post dilatation?
Yes,
Yeah, with a
we're doing
4.
yes, we're doing a post dilatation with a 4.
And then we can see the IVAS.
Yes, please.
And you need to post dilate that overlap area, otherwise your IVAS
Absolutely.
catheter might not.
Yes, absolutely.
Fazil,
And also for great
uh,
long-term
ma'am.
results, you need to do that.
Fazila ma'am, I'll
Yes.
come back to you. We'll go for the final result. Just give us 8 minutes break. Going for a lecture. We'll come back to you again, ma'am. Be online.
Okay.
Dr. Sandeep Mishra, please, he delivered his talk on CTO toolbox.
Fazila,
Yes.
this is Dr. Ranjan Datta. It's a fantastic job you are doing.
Thank
We
you.
look forward to see an excellent finish after a few minutes.
Fingers
Later.
crossed. Thank you. Yes. Thank you.
We'll come back to you once again.
Yes. Thank you.
Dr. Mishra, Professor of All History Medical Science, he is one of the dynamic interventional cardiology in India. He was the first editor of Indian Heart Journal. Dr. Mishra, please.
Huh?
Good afternoon, everybody. First of all, I have to thank Dr. Mantosh Panja and SCI for giving me this opportunity. in this wonderful place. I can have my slides. I will go on with it. And wonderful hospitality as well, and also Professor Anjan Lal Datta and all the respected people who are here. I think wait for a couple of minutes, and I think we'll
Slides, please.
So what I was asked to talk about was CTO toolbox. As all of us know, most of the frontiers in intervention cardiology have already been taken up, and I think few remaining ones are, of course, CTO PCI. And all of us know that this particular area is still sort of totally unconquered, and we of course need experts to do it. And, the first thing to know is to understand the toolbox that is available with us, so that we can use these tools nicely to get what we wanted. So we know that it is a tough one, and we really need some interesting tools and innovations to overcome this condition. So what we do need is some modifications in guiding catheter, guide wires, micro catheters, balloons, and tools for imaging, and of course technique. So technique is, I think, one of the most important things. Dr. Pratap Kumar is also here. He will, I think, vouch for it. So we need hardware adaptation. And what adaptation do we need for guide catheter? Basically, what we need is more support. And there are several options. We have Empla EBU catheter, deep seating, child and mother. I will come to this in more detail. Of course, we need a guide wire. A very important tool, I think most important tool in this particular situation is a guide wire, because 90% of the CTOs fail because of the guide wires. Only 10% fail because of anything else. So guide wire is the most important thing. We basically choose guide wires according to strategy, as I will come to that. But important thing is two characteristics all of these guide wires need to have. They need to have greater pushability and penetrability, and they need to have a higher lateral support. And again, I will come to that. Balloon catheters, I think we understand we need a lower profile. Micro catheters we do require, and stents also we require a good trackability, deliverability, radial force, etc. These are just regular things all of us know. Coming to guide catheters, as I said, we need the higher guide support, and I think that is very critical. Guide support, we need larger guides, more coaxial placements, better supporting guides, EBU implants, deep seating using stiffer body wires, balloon anchoring using smaller guide inside called child and mother. And we can also do something in case with a long sheath and then get extra support. So basically, support is critical for the guide catheters. This is just an example of guide liner, one of the child and mother guiding catheters. I think all of us know about this, so I don't need to go into more details about this. But coming to wire, and I think that is the critical aspect, and particularly there are two important things: penetrability and pushability. These are two important things. And if you look at penetrability, it is the ability to puncture a lesion. Now, if we look back, how is CTO different from any other kind of intervention? So in any other intervention, what you have is a lumen there. All you need to do is to, move your wire keep the wire in the lumen, cross the lesion, and then go ahead. So you really don't need to, push against a very hard tissue or something like that. On the other hand, CTO is a totally occluded artery, which is occluded by different material. So what you need is, you need to penetrate this whole thing and not just, move along that. And not only penetrate, you need to, push your devices, etc., also through this particular block. And that is the main thing. So for penetrability, what we realize is that there are several things on which the penetrability depends: tip load, tapered tip, wire support, balloon support, etc., which we already discussed. But most important thing is tip load. And I will come to that, how that is very important. The second important thing is, of course, pushability. And because, as I said, not only you need to penetrate with wire, you need to push that wire further and further across the resistance, which is a totally occluded material. and you need to push through that. And for that, what you really require, a lot of things are there again, but the critical thing is the lateral support that you have with the wire. So two more important things in wire is, first of all, we need a pushable wire. Second, we need a wire which has, so pushable means higher tip load, and we need a wire through which can go through the blocked area, and not only go through, other devices can go through also. So we require a higher lateral support. So these are two critical things about any CTO wire. But having said that, we need choose the CTO wire according to the strategy that we are taking for crossing the CTO. And the different strategies all of us know are sliding, drilling, penetrating, and push and torque technique. And I will come to that, what exactly is meant by what, and what kind of wire to choose for the strategy that you are choosing. So which wire to use for a micro channel? All of us know that the wire that works best in this situation is a sliding type of wire, which can easily slide through the lesion, and especially if you have to slide through the micro channels as well. So a sliding kind of wire is the best wire for these particular situation. What are the characteristics of this sliding wire? Naturally, the tip load is slightly higher. As I said, for all CTO wires, you require a little higher tip load. Normal tip load, BMW, you know, is 0.7. Run through wire is 0.6. Here we require a tip load of around 1. That is the ideal tip load. Second important thing, because it has to go through a highly resistant area, so it has to be highly lubricious. So even in micro channel, you need a highly lubricious wire, probably polymer coated. And then lastly, what I said was that important thing is to have a lateral support, because there is some resistance. So you have to overcome that resistance. So you need a lateral support. Some of the examples of these kind of wires are Fielder FC, XT, and XTA, which is a specialized wire. Fielder FC, as you know, has a tip load of 0.8. It is a polymer wire, has covered with polymer, not a polymeric wire. It's a stainless steel wire, but covered with a polymer. But important thing is that it has got a long coil, 110 millimeter coil. So that is one important thing to consider with Fielder FC wire. Another wire which is even better penetrability is Fielder XT wire, which has got same tip load but higher penetration, because it's a penetrating wire. And it has got long radio opaque material. Important thing to remember is it's not 160, but 110, but 160 millimeter of the radio opaque material. So that is the difference. But as I discussed with you, there are several limitations of these classical Fielder wires. First important limitation is that they are a polymer jacket wire. Therefore, when you rotate them, your rotation is not transmitted completely to that polymer part, because of there is a disconnect, and therefore you can accumulate a lot of torque there, and that can create a problem. Second important thing is, as I said, a long radio opaque segment. So the solution to this problem is to have a composite coil at the tip rather than a usual coil, and this is an example of a composite coil wire, which is Fielder XTA. Therefore, for this kind of a strategy, a Fielder XTA wire may be the best option. Now, coming to the third strategy, that is the drilling wire. Now, what does the drilling do? It crosses, when it finds a resistance, it changes the direction a little bit, and then again moves on, and once it finds a resistance, it again changes direction a little bit and goes in a new direction. So this type of wire is a good wire when you have a drilling. The fourth strategy, of course, is the penetrating. Penetrating, what you do, you don't move across the resistance, you actually penetrate through it. And therefore, you can have a penetrating wire which can go through the fibrous tissue, or it can go through the calcium. So many times we need a penetrating wire for a CTO presentation. As you can see, there are penetrating wires, have higher tip loads, have higher lateral support, and they have a tapering tip. And some of the example of penetrating wire and how much penetrating ability they have, usual ones we know are Conquest, Miracle, and Crosset wire. When to use Miracle wire? When there is a straight CTO. When there is a tortuous CTO, because it does not have a penetrating tip, so it has less likely of perforation. So it can negotiate these vessels and go through. But when you have a straight kind of CTO where there are no bends, then you can use a Conquest Pro wire, which has got much higher penetrability, more lateral support, etc. Coming to the last technique, that is the push and torque technique. Here what you do is you make attempt to cross, then you rotate, wait for some time for the wire to take position so that it can take a new direction, and then you push. The typical example is dia wire, which is now very frequently being used in these situations. Dia wire, I have to tell you, it's got a very special wire because it has got a very special type of coil, which is even different from XTA wire. Now, this coil, what it has is there is one single coil in the center, and then surrounding it, there is a rope coil. So what happens is that pressure which is, or the torque that is transmitted to the central coil get transmitted all across the wire, so that this lack of transmission that we saw with feeder wires is not present with Gaia wires. Only important thing that to remember is that you have to move very, very slowly. You have to move, wait for the wire to take position, and then move forward. So you can't do a drilling or a penetrating technique with this particular type of wire. This is an example of Gaia second, and you can see this very interesting composite rope coil, which is a very special type of coil used for Gaia wires. So I'm not going to details. What I have tried to tell you was that torque transmission is much better with Gaia wires. So you don't have this whip motion that you see with other kind of wires. When you keep rotating, then a point comes where your rotation does not get transmitted to tip. Rather, there is a loop formed in the just proximal to the tip. That loop will not be formed if you use this particular type of wire, which is the Gaia wire. Now, coming to another frontier, that is the retrograde CTO. Now, understand that retrograde CTO is different from antegrade CTO because you have to cross the donor vessel first, you have to cross the collateral channel, and then you have to retrogradely penetrate. And then finally, you have to use an externalizing wire to do the whole procedure. So you require not one type of wire, but 3 types of wire in this particular technique. So which wire to use for negotiating a collateral channel? Now here you require a slightly different characteristic wire. You require a wire which has got the least tip load. This wire should have least tip load because it's a long way to grow through a normal part, which will be normal donor artery and a collateral channel. Both of them don't have any stenosis. So you need a very, very low tip load, could be 0.5. But you also need a wire which has got a very low friction, so very hydrophilic or even polymer coated wire, and improved torque transmissions because you have to take these bends of the collateral channels, etc. So which wires are commonly in use? Cheyenne blue, there is another fielder XTR, and Cheyenne black. Cheyenne blue, now you see the tip load, unlike any other wire, is only 0.5. And also you see it's a hydrophilic wire. It's got a composite coil technology so that it will negotiate these bends and turns. But the problem with fielder wire is it's a hydrophilic coated. What you require is a polymer jacketed wire, which is even more, which has less friction. And therefore, fielder XTR can be used sometime, which has got a polymer jacket. The only problem is that I think these are moving by themselves, so I don't know. So this last wire is a Cheyenne black wire, like Cheyenne blue, but more penetrability because a higher tip load of 0.8. This is the only difference from Cheyenne blue. These are the wires that are used for retrograde presentations. They are like antegrade wires, but there are 5 different types. I can't go into details of that, so I'll just leave there. Coming to wires for externalization. Now, wire for externalization, what characteristics do we need? We need longer wires. Remember, we have to cross from the donor vessel, go through the retrograde, and then come out of the groin. So that you require a much longer wire, 300 centimeter wire. Also, you require higher lateral support because long way to go. But this wire should not penetrate, do not perforate. The basic problem with these wires are that they can perforate the collaterals while you are trying to cross with a balloon or stent or something like that. So that is the most important part. Here is one example of a guide wire for externalization. And then other interesting things that you use in CTO situations are micro catheters. And we know there are several types of micro catheters available with us. The one which has got the least profile is fine cross, and therefore it is very useful for antegrade penetrations. On the other hand, for going through collaterals and actually slightly dilating them or expanding them, we require a special type of catheter which is called the Corsair. The characteristic is, again, it is a soft tip wire, a soft tip catheter, which has got a braiding pattern on there. So you have 2 wires and then there is a braid along that. And that particular thing helps to slightly negotiate the collaterals without damaging them and also dilating them where required. Only thing to remember is that you can give 10 turns in one direction, then you have to wait. And when you are coming out, you have to do the opposite turns. Tornos microcatheter is useful for relatively more tougher situations where you require more pushability. So if there is a calcium somewhere, maybe you want to use this Tornus microcatheter, which is like Corsair, but little again useful against more tougher lesions. Then turnpike catheter is a metallic catheter, more useful for antegrade techniques when you require more lateral support. More support you want, you use a turnpike catheter. On the other hand, crusade catheter is one which has got 2 lumens. So it is a 2 lumen catheter. Through the same catheter, you can do a parallel wire technique. It is also very tough because it's a metallic catheter, but through 1 lumen, you do pass 1 wire, do cross wherever you can. Then if it doesn't go further, you use the other lumen to do a parallel wire technique. So this is how it is also useful in antegrade technique. Again, as I said, fine cross, lowest profile, useful for antegrade, Corsair, soft kink resistance for retrograde, collateral channel, Tornus, again retrograde to collateral channel, but with enhanced pushability wherever some calcium is there, higher profile but risk of damage, Tornus, again, even higher penetrability, turnpike, metallic tip, more lateral support for antegrade, and crusade, dual lumen for parallel wire technique. Then I'm just finishing. So this is the coming towards the end. These are the Tazuna balloon catheters. Nothing much to say except they have very low profile. And then we have some special catheters. I think Dr. Goel will talk about it. Cross-boss CTO catheter. 2 important things. One is the catheter, which can be crossed through the media and intima. So it can cross through the collateral, through the false lumen without perforating. That is the beauty of this particular thing, that it can move in the, between the 2 lumen of the vessel, between the vessel layer, in the false channel without perforating.
So, Mr. Please summarize, please.
Yeah, this is the orienting balloon, which can, basically use to find the true lumen. These are the IVAS, and these are front-loaded IVAS. Unlike other IVAS, where you have the imaging far behind, these are at the tip, and therefore you can use it, placing it in the true lumen itself. So I think it's already gone, so that's it.
Please summarize.
I can come to the last slide if you want, but I think it's over there.
Last slide, please.
If we can.
Just focus. Just a moment for 2 minutes.
Okay. So basically, these are the summary slides. So as I said, antegrade technique, you have to choose. If you use sliding technique, use Fielder XT, wire, FC, or pilot wire. If drilling, then Fielder XT, cross it, Conquest, Miracle, push and torque, Gaia. For retrograde, already I told you, for crossing the donor vessel, Sion, or Fielder XT, R wire. For traversing the microchannel, penetrating, occluded channel, then antegrade, any wire like antegrade, and externalization, retrograde wire. For balloon catheter, the micro catheter I already showed you, antegrade crossing, fine cross, collateral crossing, Corsair, calcific lesion, Tornus, support required, turnpike, and antegrade parallel crusade. I'll just leave. Thank you so much for your kind.
Thank you, Samir, for excellent presentation, a brilliant exposition of the different type of catheters. And thank you. We have come back to Fajila.
Hi.
Please.
So
yes,
we finished our case, and we used a 4x12 NC Euphora to do post dilatation, and we went up to 20 atmospheric pressure. Once we did our post dilatation, we did a thorough job of it, and as you had rightly pointed, we also did a post dilatation where the 2 stents meet. After post dilatation, this is how the vessel looked. We then proceeded to take our IVAS catheter, which went fairly easily, and yes, so IVAS went, and let's have a look at the final IVAS shot. And this is the spider view where you can see the LCX is doing absolutely fine. And let's have a final look at the IVAS. And as you can see in the IVAS, after post dilatation, the stent is well opposed, and the diameter is 3.8, nearly about 4 in the left main, and the LCX looks fine as it does in the angiograph. So overall, we would say that this was a reasonably satisfactory result, and those are the last images of the IVAS.
Thank you so much.
Thank you.
Thank you.
So congratulate.
Thank you.
So we are thankful to Fajila for excellent demonstration of the multiple lesion and multiple vessel with complete revascularization. Thank you very much.
Thank you. Thank you.
Thank you once again. And now I would like to call upon our next speaker, Dr. Ramdev Yadav. Sir, please.